So good evening to all.
sir.
Yeah.
I'm Dr. Aneya Mazumdar from Nayar Hospital, Mumbai, and I'll be presenting this case. With the informant being mother, my patient is a 6-month-old male child, a resident of Andheri, born out of non-consanguineous marriage. First by birth order, came with chief complaints of absent anal opening since birth, passing stools from a surgically created opening over the left lower abdomen. As per mother, the child was born as a full-term normal vaginal institutional delivery with a birth weight of 2.7 kgs. Patient was evaluated and noted to have an absent anal opening and was referred on an urgent basis to our hospital for further management. Patient underwent some x-rays, following which patient underwent a surgical creation of a opening over the left side of abdomen, from which patient is currently passing stools of yellow in color, which are well formed. Patient was evaluated on OPD basis and has now been admitted for further definitive procedure. Currently, patient passes urine in a good forward stream, and there is no history. There was no history of any meconiuria at the time of previous surgery. There was no history of any swelling over back. There is no history of any urinary complaints or any urinary infections in the child. There is no history of any cyanosis or limb anomalies. Currently, patient is passing urine in a good forward stream and is on distal stomal washouts. It is now admitted for definitive procedure. So in past history, the child has underwent a stoma creation over the left side of abdomen on day 2 of life. In antenatal history, the mother was an ANC registered mother, immunized, had no any history of any infections during pregnancy, any febrile illnesses during pregnancy, no history of any comorbidities detected prior to or during gestation. Antenatal scans were normal. The child was born out of a full-term normal vaginal delivery, cried immediately after birth with a birth weight of 2.7 kgs, following which the child was noted to have an absent anal opening and was referred for further management. Presently, the child is on weaning diet, has achieved all developmental milestones as per age, and is immunized as per the schedule. So, may I move to examination, sir?
May I ask some query in the history also?
Sure, sir.
You have told that there is a stoma present in the left lower
Abdomen.
quadrant. What
Yes,
type
sir.
of stoma is there? It is divided, loop, or something?
So I've mentioned it in further my examination part, sir.
Yeah, you will tell that.
Yes, yes, sir.
Anything history related to family? Is any?
No, sir. No history of any complaints in any other family members.
With this similar problem
No.
or any other congenital anomalies?
No history, sir.
Have you taken any dietary history of the mother?
Yes, sir. Of the mother, sir.
Yeah, mother.
She's consuming a vegetarian diet, sir.
Okay.
Yes, sir.
Okay, go ahead.
Yes. So on examination, the child was examined in a well-lit room after parental consent, with the child lying in mother's lap. The child was active, alert, and playful, well hydrated, with a weight of 5 kg and height of 60 centimeters. Of April, the pulse was 100 per minute, taken in the right radial artery. BP was 80 by 34 millimeters of mercury in the right brachial artery. The respiratory rate was 54 per minute. There was no signs of any pallor, icterus, cyanosis, clubbing, or lymphadenopathy. Examination of spine showed no visible swelling or defects. Examination of limbs was normal. Coming to systemic examination, per abdomen examination, on inspection, the umbilicus was centrally placed and located. Abdomen was normal with no visible dilated veins or lump. A loop colostomy is noted over the left lower abdomen with yellow stools seen to be coming from the lateral opening. There's no evidence of any excoriation or prolapse of the colostomy. There is no evidence of any peristomal swellings. Hernial orifices were normal. On palpation, the inspectory findings were confirmed. Abdomen was soft, non-tender. No palpable lump or organomegaly. A loop colostomy was noted over the left lower abdomen with yellow well-formed stools noted from the lateral opening. There's no evidence of any swelling or lump surrounding the stoma. On percussion, a tympanic note was heard all over abdomen. On auscultation, normal bowel sounds were heard. On perineal examination, there was absence of anal opening. Buttocks were well formed. Anal pit was seen. Natal cleft was well defined. Anocutaneous reflex was present. On genital examination, urethral meatus was at the tip. Urine stream was good. Scrotum was well developed. Bilateral testes were descended. Rest of the systemic examination showed no abnormality. So to summarize, my patient is a 6-month-old male child with anorectal malformation with a sigmoid loop colostomy with no obvious associated anomalies.
Okay.
Yes, sir.
So you have the previous X-ray of the patient during neonatal period?
Yes, sir. May I show the investigation, sir?
Yeah.
Yes.
So read this X-ray, please.
Sir, should I read the plain X-ray first or the CT-PL first, sir?
You go for the plain X-ray and tell the what is the purpose of this plain X-ray, and then go for the cross-table probe. Yeah.
Yes, sir. So the plain X-ray, erect abdomen was taken. Also, a lateral X-ray was taken. So in the plain X-ray, we took it to see for the spine to rule out any associated spinal anomalies, to rule out any evidence of perforation. So air and the diaphragm was ruled out, and also to rule out any evidence of pouch colon, which would appear as a dilated bowel loop. Accommodating more than 2/3 of the abdominal cavity.
Okay.
Also, on the examination of spine, we took a lateral X-ray because the X-ray better defines the any spinal anomalies if present. So spine was appearing normal, sir. On CT, sir.
Yeah. Go ahead.
Yeah. So on a cross-table lateral prone X-ray was...
Comment on the plain X-ray chest and abdomen. You have told about the spine.
Yes,
you have
sir.
told about the perforation. You have told about the pouch colon, right?
Yes, sir. Yes, sir.
Anything else you want to comment on the chest?
The chest,
not in this patient,
for the
but
heart,
you want to see?
Heart shadow, sir.
Yeah, that you can also see sometimes there's
Yes.
yeah. Okay, go ahead for the letter.
Yes, so cross-table lateral, prone lateral X-ray was conducted in this child. On this X-ray, we can see the air in the rectal pouch is just at reaching the PC lines. So it appears to be a high anomaly, sir.
High anomalies. Okay.
Yes.
Can I ask something related to this?
Yes,
what are the ideal time to go for this cross-table prone lateral field
So
number one?
for a CTPL X-ray to be conducted, we have to ideally wait for 18 to 24 hours after birth because we want the air to go down as distally as possible. When we are taking the X-ray, we put the child in a genopectoral position with a bolster over, under the pelvis. We keep the child in that position for 3 minutes to allow the gas to move as distally as possible, displacing the meconium. And the child should be comfortable, should not be crying. And the X-ray, we focus the X-ray at the trochanter, greater trochanter, with the both the femurs we overlapping each other, and in this position we take the X-ray.
What is the advantage of invertogram versus this prone cross table?
So in invertogram, there is a risk that the child is uncomfortable in that position, so the child will be crying. So there can be a false this high anomaly can be noted. At the same time, the child is at a risk of aspiration because the child is held in an inverted position. So this is a more comfortable position for the child.
Anything
risk of
else?
aspiration is less.
Anything else you can explain in invertogram? There is just some correlation with ARM with other anomalies. I'm giving the hint to you.
Spinal anomalies and urological anomalies.
No.
So
Put in
let
invasive.
me give you
Sir.
what he's actually wanting to know. Have you heard of the Vactral
Yes, sir.
group of?
Yes, sir.
Yeah. So what does that mean? What are the parts of the Vactral?
Vertebral anorectal tracheoesophageal anomalies, limb anomalies.
And look at all the alphabets. All the alphabets represent something or the other.
Cardiac anomaly.
Yeah. What does R stand for?
Renal anomalies, sir.
Renal anomaly.
Yes, sir.
Okay, carry on.
Yes, sir.
Hello, can you hear me?
Sir. Yes, sir. Yes, sir.
Yeah. So we have the invertogram which used to be done before. It's still being done, and you also have the cross table lateral.
Yes, sir.
Which was who described it first? The cross table lateral. Where has it originated from?
Narsimha Rao.
Yeah, from CGI Chandigarh.
Yes, sir.
Yeah. So, is there any invasive method of assessing anorectal malformation?
Sorry,
I'll
sir.
give you a hint. Is there an invasive method of evaluating anorectal malformations, particularly the imperforate varieties? It's been described in Japan.
Needle aspirations.
Sorry?
Needle aspiration can be done with the contrast.
Yeah, not needle aspiration. You put in the needle from the perineum into the blind pouch and inject some contrast, and that gives you opacification and also gives you a better understanding of whether there is a fistula or not.
Right, sir.
Yeah. Carry on.
So CTPL was done, and the child was taken up for a loop sigmoid colostomy. High sigmoid loop colostomy was done on the child. Post-operatively, on follow-up, the child was kept on distal stomal washouts, and at 6 months, we have conducted a special X-ray, a pressure-augmented distal cologram we have gotten done on this child, sir. And child is now presently been admitted for definitive procedure. So, should I read the X-ray, sir?
Yeah, sure.
Yeah. So, this is a special X-ray with the dye injected through the distal opening or lateral opening, distal opening of the loop stoma. A balloon was a balloon catheter was inserted into the loop stoma, and it was hitched, and the dye was injected, and X-rays were taken in the AP anterior, posterior, and lateral position. In this, we can see the rectal pouch being defined with the contrast, as well as a little amount of contrast. The beaking of contrast is being seen in the second X-ray, which is actually the contrast being passing into the from the fistulous tract into the urinary system, and perurethral the contrast was extruded out. So
what would be the best contrast to use in this study?
Water soluble contrast, sir. We use a gastrographene dye. 76% gastrographene dye, which has been diluted in 1:1 ratio with the NS.
What is the problem with using barium? Thin barium. That used to be done before, wasn't it?
Yes, sir, but there's a risk that the barium when injected into the urinary system, one is there's getting infection, and it
barium
cannot
is
be.
not toxic. Does it matter?
Sir, it will form stones, sir. So because there is no distal pouch, and it can remain in the ectatic pouch, and it can cause stone formation later, not clear out very easily, which is possible with a water soluble dye.
Yeah, so passing it out in the urine is not a problem. The problem is that retention
Yes, sir.
barium in the blind pouch can lead to a formation of a stone,
Yes,
which
sir.
will then interfere with your surgical procedure.
Yes, sir.
Yeah.
And also, if the pouch get perforated because of the pressure, then there is a barium peritonitis that is very much create a problem. It's
Yes.
become total plastering of the abdominal cavity.
Yes.
Go ahead.
That's also investigations. These are the only investigations.
So here you are looking the fistula probably going into the urethra, and you little bit bladder is also visualized. If I'm not wrong.
Not very clearly, sir.
Yeah, but there is a shadow just in front of this lateral film. There is some shadow which is seen. Yeah.
Yes, sir.
So there is a chances that there is a which type of fistula where you can get a dye into the bladder.
So prostatic, rectoprostatic or rectovesical fistula.
Okay.
So according to you, where would you classify this anorectal malformation? Is it high? Is it intermediate? Low?
High NO.
Okay. What are the reasons for it?
So
what are the criteria
in the CTPL that was conducted, sir?
Do you know of any lines which can determine the position?
Yes, sir. Yes, sir. So the CTPL which was done, sir, the PC line and the I line, the pouch was extending, just stitching the PC line and not actually crossing it. That is why I'm classifying it as a high anorectal malformation, sir.
Yeah, so you should have mentioned that.
Yes, sir. I've mentioned it previously when I was.
Sorry, my bad. I didn't hear that. Right. So I mean, what is the extent to which we can question you? Are we going to discuss the management also, or are we just going to?
Yes, sir.
I think, sir,
whatever I can ask you question.
Sorry?
Sir, I think before management, we have to discuss details about the PC line, I point, in absence of the sacrum, where we can think. Yeah, that is.
Please go ahead. Please go ahead. No, why I asked that question was that we should know when to stop.
Yeah.
Yeah.
Yes.
So tell us something more about the PC line and the eye point or the eye line.
So the PC line extends from the, it's a pubococcygeal line which extends from the superior surface of at the midpoint of the boomerang shaped pubic os, symphysis, and from there it extends to the lowermost sacrum, because the coccyx is not yet ossified and is not really visible in the neonatal period. We just hold it till just below the sacral point, and the eye line is passing parallel to this line, just through the lowermost point of the ischial bone, which is the eye point. This forms the PC line. So the PC line and I line are the two lines which run parallelly, and we assess the rectal shadow or the pouch shadow, which where exactly is extending up to. If it is crossing the I line, we consider it as a low anomaly. If it is between the PC line and the I line, we consider it as an intermediate anorectal malformation. And if it is ending before the PC line, we consider it as a high anorectal malformation.
But this is the normal phenomena, what you have told. So suppose the patient have a sacral hypogenesis or agenesis, then how will interpret
so in that case, we will take the eye line and just parallel to it at midpoint of, not midpoint, sir, just at 1/4 superior, 1/4 inferior, 3/4 of the ischial bone, we consider as the end point, and we'll pass the line from P to this point and then extend it beyond, and these two lines will be considered.
So this PC line and the
Right,
I
sir.
point is
Right, sir.
indicate what? Basically, these 2 points indicate what?
So the PC line is, it basically indicates the upper border of the levator ani.
Yes.
Yes, sir.
Okay.
And I consider lower border.
Okay. What are the pitfall of this invertogram or the cross-prone lateral field? Any
So
idea?
the pitfall is that if the child has not been kept for 3 minutes, if the child is crying, then we can get a false high anorectal malformation. At the same time, if we do it very early, the air would not have reached to the distal most point. And in that case, we can get a false higher anomaly. At the same time, the overlapping of the femur is very important so that the pubic bone and everything can be seen very clearly. And if we have not kept the patient in genupectoral position with a bolster properly, then also we will not be getting proper.
So how long is it advisable to wait before
3 minutes, sir. 3 minutes.
3 minutes.
Yes, sir. Sorry,
In 3 minutes.
in the position, 3 minutes in that position,
No,
sir.
no, no.
And
I'm
18 to 24 hours after the birth, we wait, sir.
Okay. So, few words about the colostomy.
Sir.
What is the difference between doing colostomy in sigmoid versus transverse colostomy? Advantage and disadvantage.
Sir, the advantage of doing a sigmoid colostomy is that there is the distal pouch can be cleared out and kept clean much easily. There is a less chance of prolapse as compared to the transverse colon, which is difficult to clear out. The disadvantage of it is that we don't have, if we don't do it at high sigmoid colostomy, and if we do it in the middle, then we will not have enough rectal pouch for pull through. That is the disadvantage.
What other advantage is the sigmoid colostomy? 2, 3 things which is most important you have left out. Yeah.
Easy to perform,
Wash.
sir. Easy to wash out the distal. We get
What
a
else?
fixed point, sir. Chances of prolapse are less, sir.
Okay. What else?
We can easily mobilize it if for pull through, sir.
What else? Is there any communication with urinary tract? What happened?
In transverse colon, there is if the infection keeps, if the distal pouch is not cleared and there is a fistula, there is a risk of metabolic acidosis that might happen with the transverse.
So that is less in sigmoid colostomy.
Yes, sir.
So that you have to also tell.
Yes.
Okay. So these are the advantages, and what about the
What else? Sorry, there's one more advantage, which you will realize when the child grows older.
Yeah.
The scar is small, sir. Incision.
No, the position of the scar. If you're doing a transverse colostomy, it will be visible.
Right, sir.
If you're doing
this
a sigmoid
is lower
colostomy,
abdomen.
it will get covered in the undies and in the trouser or whatever the child wears.
Right, sir.
Isn't it?
Yes.
The consistency of the stool in both the places is different.
Right. So it's more watery in consistency in transverse, whereas it's a well-formed stools in
cleaning up the distal in transverse colon.
Sorry, sir?
Cleaning up the distal colon in the transverse colostomy become difficult.
Very difficult. Yes, sir.
Doing the distal lupogram is also become difficult.
Difficult, sir. Yes. Sir.
So these are the points you must remember. Okay, sir. Vikesh sir, over to you. So you have done the distal lupogram in this patient, right?
Yes, yes.
And this is the high type of rectourethral fistula.
Yes,
Okay.
yes.
So what are the other investigation by which you go for the treatment in this patient?
Micturating cystourethrogram, sir.
Okay.
So
What others?
pressure augmented cholesterol.
No, after the neonatal period.
Ultrasonography I would want to get done, sir. For the
Can you roll up ultrasound in neonatal period?
yes, sir. See for spine, sir, and ultrasound KUB to rule out any other associated renal anomalies, because that way we can prognosticate and counsel the patient's parents.
So after doing colostomy, in the follow-up, you can go for the ultrasound, right?
Yes.
Cardiac evaluation.
2D echo, sir. Yes,
Yeah.
sir.
So you have to tell all the things now before planning for the surgical intervention.
Yes, sir.
Sir. So, what are the way you are going to manage this patient? This patient have a fistula which is high in the rectoprosthetic urethral fistula. So, what procedure you will like to do in this patient?
So I would want to go for PSARP, sir.
हाँ हाँ बोला ना.
Hello, sir.
Yeah.
Yeah.
Okay.
I would want to go for PSARP in this child, sir.
PSRP.
Yes, sir.
Okay. But what are the other way to handle this patient?
Sir, laparoscopic assisted PSARP can be done, sir.
Can also be done in this patient.
Yes, sir.
Okay. So, just coming to the management, I would
sir.
like to ask you, what are the
Sir.
common classification of anorectal malformation, which is based on the management? Although there are many classification, you all know, right?
Sir.
What are the common classification on which we are planning for? This is the high, intermediate, and low in male and female.
The PNAS classifications.
What is that?
So for males, you have high in which there is rectal atresia with fistula, and there is rectal atresia without fistula. So then there's an intermediate with rectourethral, rectobulbar fistula, and then there is a low, which is rectoperineal fistula. So similarly, in females, there is a high.
It's not called a rectoperineal fistula. It's called a perineal fistula.
Yes, it's also.
Yeah. Why?
Sir?
Why is it called a perineal fistula and not a rectoperineal fistula? If you read Peña's classification, he mentions it as a perineal fistula.
Perineal fistula. Yes, sir.
Yeah. So, what it means is that the distal part of the
is
there.
There is a normal opening with normal anal opening with a fistula.
Yeah, so it's not a normal anal opening, it's an opening in the perineum.
Small opening in the perineum.
Yeah, it's an opening in the perineum, and it is it will not be a continent opening. You know why will it not be a continent opening?
Because it's outside the sphincter muscle.
Yeah, it's outside the muscle complex.
Yes, sir.
You know?
Yes, sir.
You're fully aware of the striated muscle complex which Peña has, right?
Yes.
Yeah.
Yes.
And you know how to identify it?
Yes, sir. That's
So
striated.
I'm just asking you this so that you become aware of it, and we don't need to go into the details of.
Yes, sir.
So what are the ways in which you can identify the muscles?
So the striated muscles and the parasagittal muscles, sir.
Yeah. So how
Yeah.
there are
So,
various ways of. One is you can either see it if it is well developed. If you can't
Yes.
see it, what are the other ways of identifying the muscle?
with the muscle electrical stimulators, sir.
Yeah. And the electric stimulation can be
Yes, sir.
done with.
Give you the out.
So how
extent
do you
of-
do it? So
Sorry, sir.
how do you identify it by electrical stimulation?
Uh, the point at which there is maximum contraction.
No, no. So what do you use for the electrical supply? One is the muscle
Electric
stimulator you said.
muscle stimulator, yes, sir.
If suppose you don't have a muscle stimulator, can you still identify the muscles by
cautery
Yeah.
can be used at a very
So,
small
but there are,
voltage.
what would you do in that cautery? I mean,
The
you
pins,
can damage
fine
damage
tip,
the
fine tip,
sorry.
with a fine tip cautery, sir.
Yeah, fine tip. But how do you how do you do it? That's what I want to know. What do you do in the cautery settings?
Not very sure, sir.
Hmm?
I'm not very sure, sir.
So if you keep the cautery settings the way you use it for the
It'll
surgery,
burn.
you'll burn the muscle.
Yes. Yes. If you
So
keep it very low.
so you put it on a very low setting, and you don't use the cutting mode. You use the
Coag-
coagulation mode,
Yes, sir.
isn't it?
Yes,
And
sir.
so with a very low current, you can identify the muscle contraction without severely damaging the muscle. Some amount of damage will be there, but it's okay.
Yes, sir.
Yeah.
Yes.
Can you tell the step of PSARP from where
Yes,
you
sir.
will give the incision and posterior and interior? Yeah.
Yes, sir. Yes. So I'll keep the child in a jackknife position, prone position with legs a little in a frog leg kind of position.
What about the catheter?
Prior to surgery, I will catheterize the child and then put the child in this
Yeah.
position. Sir.
Okay. Suppose catheter is not going into the bladder, then what are the options to manage?
So one is we can use the lacrimal probe or a coude catheter and try to pass the catheter, sir. If it's still not possible, we can do a cystoscopic examination and insert the catheter.
Okay.
And
Then after
then
Catheter is not going. Do you think the cystoscope will go?
sir, in a bigger child, cystoscope can pass, sir. Catheter may not go because of the fistula being very large and it entering inadvertently into the fistula. So,
Suppose you're not being able to catheterize the bladder, what would you like?
sorry, sir.
Suppose you're not being able to
Sir.
catheterize
Then
the bladder.
intraoperatively will catheterize, sir.
No, you can do something before that.
Suprapubic catheterization.
Sorry?
A suprapubic catheterization.
Yes, why not? There's no shame in doing that. If you can't, it's always a better option than trying too hard and damaging the urethra.
Yes.
It's much safer option, isn't it?
Yes, sir.
Yeah. So carry on with Dr. Siddhar's question.
Yes.
Yeah.
So with the child in the prone jackknife position, with the legs in the frog leg position and a bolster below the hip. We'll take incision in the midline from the coccyx till the anterior limit of the muscle complex that we have marked using the muscle stimulator prior to starting. So once the incision, we marked the limits of the muscle complex, we'll take this incision and we'll try to remain in the midline and go layer by layer, keeping in the midline. So we'll see the skin, subcutaneous tissue, we'll see the parasagittal fibers, then we'll reach the striated muscle fibers, we'll cut them in the midline. Will continue to remain in the midline till we see the whitish glistening fascia of the rectum, sir. At this point, we will kind of take stay sutures over the rectum and incise it. Just when we are incising, we have to be very careful not to go too distally, because then we are at risk of injuring the urethra or the fistula rather. So we will incise the rectum, we'll open it, we'll take stage sutures, we'll look for the we'll fistula. At the site of the fistula, we'll take a stay through the fistula and hold it. And then in a semi-circular fashion, we take stay sutures over the rectum, just proximal to the fistula, and we do a submucosal dissection at this level, and we continue to do the submucosal dissection till we get a very clear areolar plane between the urethra, between the urethra and the rectal pouch. Once we have dissected, then we'll close the fistula, and this rectal pouch we will mobilize. We'll go circumferentially full thickness and mobilize it by cauterizing the bands and the vessels, and try to get it and as much as we can mobilize to reach within the sphincter muscle complex that we have marked. So once we have dissected it all around circumferentially as much as we can, and the pouch is reaching up to the point at the surface, and we see there is no pullback, the dissected part is remaining out. We know that there is no traction, so we know that we can now go and do the anoplasty of this segment. So once we have made this much mobilization of the rectal pouch, we will now fix the rectal pouch with the muscle, and we will then close the once we have confirmed there is no bleeding, there is no other any points of hemorrhage from anywhere else, and we have confirmed hemostasis, then we will close the levator sphincter, we'll create the perineal body, we'll do the anoplasty and close the skin and subcutaneous.
So you will use dilator to check whether it is stenotic or not.
Yes, the anoplasty will be done over the dilator.
And I think there are quite a few other things that you can do before you actually do the anoplasty. What would you do? Suppose the rectal pouch is very bulky.
We can taper it, sir.
And how will you taper it? What would be your guidelines? How much will you taper it? And for how long? What length?
If it is too dilated, sir, we would like to
What
kill
is
the
the
peritoneal reflections.
What is the whole purpose of identifying and defining the muscle complex?
Muscle complex.
Yeah. So your aim should be that the part that you're
Fitting
pulling
within the muscle complex,
it
it's
should
not
within
very
the vertical.
fabulous.
It should be within the vertical fiber,
Yes, sir.
right?
Yes, sir.
Now, sometimes what happens is that the vertical fibers are not broad enough to accommodate even tapered rectum. What would you do in that case? What is the purpose of the vertical fiber?
They give the continence.
No. What else? I mean, how do they help in managing the act of defecation and the continence?
The rectalis sling is the one which maintains the angle. And it,
See, if you are doing an sagittal
yes,
this thing,
yes.
then you don't talk of the puborectalis sling. I mean, the puborectalis sling doesn't exist as far as pinea is concerned, isn't
yes,
it?
we
You
open.
have, yeah. So what is the disposition of the fibers? How do you describe the fibers that you see in the muscle complex?
The striated fibers and the
So these are striated muscles, but what would you,
the
how do
vertical
you,
fibers and the horizontal fibers.
there's no horizontal fibers.
The
You have the
parasagittal
parasagittal fibers and the
and
vertical
the
fibers,
vertical fibers.
right?
Yes.
And what is the function of the
Perpendicular.
vertical fibers? What would happen? What will, I mean, it's a very simple thing. If you apply your mind, you can answer it. How would the vertical fibers
The
contract?
funneling, it funnels
The funneling is provided by
the levator muscle
not the
and the
levator muscle.
vertical fiber.
The what is the purpose? What is the way in which the vertical fibers contract? When they contract, what will happen to the anus? It'll get pulled up,
Closed, pulled up.
isn't it? When the vertical fibers contract,
Yes,
they'll pull up the anal orifice, right?
yes, sir.
And it'll shorten the length of the bowel which the stool has to traverse,
And yes, sir.
isn't it?
Yes.
So if suppose you're
Will
not
come out
being
very
able,
quickly.
if suppose you're not being able to taper the rectal pouch to an extent to accommodate in it, what are the options that you have?
Like,
How much will you taper? How much can you taper? And what happens when you taper? What do you do next in the post-operative period?
dilatation.
Dilatation, greater dilatation.
Yes, sir.
You have a set of dilators, and there is a criteria of how
Yes,
much
the
to dilate.
age and the
Yes.
size of dilator.
Age and the size of the. You should know that,
Yes,
right? Because that's a very important thing. If
Yes.
if you underdilate, you will not
stenosis.
have the required effect. But if you dilate, then you will damage the muscles.
Right, sir.
That is why it has to be a graded muscle over a period of how long will you continue dilatation?
So dilatation for about 2 months, sir.
No, much longer than that.
Closure.
Much longer than that.
Post stoma closure, we
Earlier,
continue.
in the early period, you do it more frequently. In the later period, you do it
We
less
can
frequently.
start tapering it.
Yes.
Yes.
Isn't it? You don't taper it, you increase the size of the dilator.
Till age appropriate size has been achieved.
Yeah. Okay.
Yes.
Dr. Jaleda, आपके you ask whatever.
Sir, just light has gone. I am connecting with some other way, so you can continue. Yeah. Now I have joined. Now I have joined.
Right. So when you do the penis procedure, what about the colostomy?
Sorry, sir.
There are two questions here.
Yes, sir.
What is the timing of the penis procedure?
Okay, sir.
So when would you like to do it ideally?
Ideally, sir, once the stoma is done and if the child is thriving well and has gained adequate weight, I would like to do it in about 2 months to 4 months of age, sir. And beyond that, once the age appropriate dilator has been.
There are some people who do it otherwise.
Okay, sir.
No, you tell me it's not okay. You tell me what is the other way of doing it. In the newborn period, what would you do?
Primary
so you said you will do a colostomy, but
who do without a colostomy, they go for direct primary procedures, primary definitive procedure.
What is the major disadvantage of that?
So there is a risk that at this point, because there is no stoma, sir, so there is a risk that post-operatively, if there is wound essence, or if it's not functioning well, the child might require emergency stoma.
Yeah, not just an emergency stoma, because if the perineal wound heals by scarring and by secondary intention, you will not get the kind of continence which you desire, isn't it?
Yes, sir.
Yeah. So that is one major disadvantage of the primary PSARP.
Yes, sir.
And that is why most people prefer to
To do a stoma
and then do the rest of
yes.
it. Yeah.
Yes, sir.
So suppose this baby also has renal anomalies associated.
Okay,
Forget
sir.
about.
Okay,
I'll
sir.
come to the renal anomalies later on. Suppose this baby is
Okay, sir.
born and you detect that the baby has an imperforate anus and also a tracheoesophageal fistula.
Okay, sir.
What will be the strategy of management?
So, I would want to, because the prognosis with the child have a tracheoesophageal fistula, there's a poorer prognosis. So I would want to do a tracheoesophageal repair at the same time with a stoma, sir. So we can take care of the tracheoesophageal fistula, get the primary esophageal anastomosis done with a stoma, so that we can divert the stools and then plan for a definitive stoma surgery at a later date, sir. Sorry, PSARP at a later date. And at the same time, I would also want to get a 2D echo done, a USG KUB done, because I want to rule out other associated anomalies, which has a higher risk of being now with a VAC.
Yeah.
Yes.
So what happens to the bowel when there is an esophageal atresia? Suppose there is an esophageal atresia without a fistula with the trachea. What will be the status of the bowel?
It becomes a microcolon collapse.
Yeah, so there will be no passage of air.
Yes.
Right?
Yes.
For the
So
bowel
it may
to
not be
distend.
detected.
No, it will be detected, but you will not know the extent of the malformation.
Right, sir.
Right? So you need some sort of contrast in the bowel for you to assess the anorectal malformation.
Yes.
And under the circumstances, the only way you can estimate it is by getting air by passage into the intestine.
Right.
Right?
Right.
So you would either do a primary anastomosis, that is possible. If that is not possible, you would do, what would you then do?
Esophagostomy, gastrostomy.
Yeah.
With the
Yeah. And then with the gastrostomy, you can
pass the air and see the
pass the air and
contrast.
then evaluate the
Rest of the
anorectal
bowel.
malformation.
Yes.
Yeah. Yeah. Now you tell me, is there any question which you want to ask us?
Sir, the vertical fibers question, sir, I'm a little confused about that.
Yeah, so what I would suggest is you look at the diagrams of pinea.
Okay, sir.
They're there in almost all the textbooks. And you see how the muscle fibers are placed,
Sir.
right? And the contraction of the muscle fibers will be in the vertical fibers, they will be contracting from above to below, isn't it?
Right, right, sir.
Isn't it? So they will shorten the anal canal, the muscles of the anal canal. That is how they will contract, right? And the parasagittal fibers are the one which will contract when they contract, it will be like a constricting contraction.
It will close, yes.
Yeah, isn't it?
Yes.
So it's a very fundamental thing when you recollect what they taught you in anatomy. The contraction of the muscle is always at right angles not at right angles, but along the
Line that it,
the line of the fibers.
yes, sir. Direction.
Isn't it? Yeah.
Yes. So the tapering point, I'm a little, I would like to know about that, sir.
Yeah,
the
so essentially the tapering is done so that the terminal part of the rectum can be placed within the vertical fibers.
right, sir, right, sir.
Right?
But if it
So
is not,
before you do the anoplasty, you put stitches along the anterior part of the vertical fibers.
to
Then
fix,
you have a flat surface, and then you place the rectum, the so-called what will function as the rectum within the vertical fibers, so that when you're closing the posterior layer, you have a complete cover of muscles on all sides.
right, sir.
Right?
Got
And that is the whole purpose of tapering the bowel.
Sir.
But I asked you something, that suppose the vertical fibers are not so well developed as to cover the entire circumference of the tapered rectum. What can you do? Think. That's why I was asking you what is the contraction of the vertical fibers, and what do the rectal fibers do? They pull up the anus, isn't it?
Right.
So if you're not being able to cover the entire rectum with
At least
the
anterior.
rectal fibers, you can place the rectal fibers on the vertical fibers on both sides of the rectum, or
Anterior and
you can complete the anterior closure, anterior stitch line, and leave a little bit behind. The purpose of this is that the muscle fiber, the vertical fibers will still be able to contract and pull the anus upwards. But if the parasagittal fibers are intact, then they will also retain the contraction of the pull through bowel.
Okay, sir.
Right? So,
yes.
I mean, in most situations, it is possible to taper the bowel so that it can be placed within the vertical fibers. But I was just asking you theoretically, suppose it doesn't happen, then what are the options? Then the option is that you shouldn't try very hard to close the vertical fibers, because then you will end up over tapering the rectum, and that may be very difficult to dilate later on.
Later on. Yes, sir.
Yeah.
Thank you.
Yeah. Anything else?
No, sir, that's it.
Sir, there is just some query mentioned in the chat box. I was just looking. So there is one query that what is the difference between the vertical fiber versus the sagittal fibers? So I think sagittal fiber and parasagittal fibers both are the vertical fibers, and the sagittal fibers are the same, what sir have told. And tapering should be done usually on the interior aspect, because you are removing the fistula side, so that area become almost divided. So you tapering should be done on the interior aspect rather than the posterior. And third thing, if it is large dilated pouch, somebody have mentioned, then you excise the pouch and then you get a normal pull more of the rectum to bring in the surface of the anal opening. And regarding the incision from the PSARP, as you have told that it should be started from the tip of the sacrum to the interior border of the future anus. Book have classically mentioned that incision should be started from the mid of the sacrum, so that you can, mid of the sacrum, lower part of the sacrum, you can say, and then you follow the exactly in the it's mentioned in some book have mentioned the tip of the coccyx, but original book have mentioned that the middle of the mid sacrum. And I
Yes,
think for the
yes.
beginning, it is a good practice to start with higher incision, and then slowly later on you can switch to the tip of the coccyx.
Okay, sir.
Yeah. The other query was mini ASRP and limited ASRP. I think this is not applicable in this patient, right? And pure esophageal atresia, somebody have mentioned that, sir, will a child with pure esophageal atresia and ARM need general anesthesia a second time after re-evaluation for ARM? Somebody have mentioned, but practically, I think if you have diagnosed TEF with ARM, if it is fistula, you will get a good amount of air into the colon, so you can make the decision where we will do the colostomy at the time of TF repair. But pure esophageal atresia is difficult to know where is the level of the rectal pouch. In that scenario, it's a little bit difficult. Either you can do the gastrostomy and push the air and wait for another few hours to reach the gas into the rectum, and then you go for. But practically, what I am doing is basically is that when you are doing the gastrostomy and transverse colon is there, and you can easily do the colostomy. And most of the time you are correct, but sometimes you may be wrong because sometimes it's made associated with a small bowel atresia also, maybe duodenal atresia or something else, then you will end up with the problem. But in cases after doing gastrostomy, while pushing the air, you can more safe to know the level of the rectal pouch. Somebody have asked, what is the indication of ASARP? ASARP basically indicated for the female patient who have a perineal fistula, either anovestibular fistula or rectovestibular fistula or perineal canal, what we are doing here in KGMU. Otherwise, for the male, it is usually PSARP. And when to go for abdominoperineal approach, as she has already told that if the fistula is high, especially into rectovesical fistula or rectoprostatic fistula, which is very narrow, which is sometimes difficult to do by PSARP, then you can go abdominoperineal approach either by laparoscopic or perineal approach. And I think these are the query which is mentioned.
Yeah, but one more thing which I would advise you to read a little more about is the part of the rectum which is opening into the as a fistula, because now
Yes,
there
sir.
is a lot of literature which suggests that the concentration of the ganglion cells is maximum in that particular part of the bowel, and that is why they say that
Not to be sacrificed.
it's not to be sacrificed. You should dissect it very, very carefully and try and preserve that portion of the bowel, because there is a suggestion that it might also be the internal sphincter region,
Yes, sir.
right? So
Yes, sir.
the chances of continence become much higher if you can preserve that
Preserve
part.
that.
Yeah, yeah.
Yes, sir.
So that is something which I think you should read up a little more about, because these are all things which are happening now. I mean, this is all recent information. So, I mean, there is no, I mean, it's not something which is universally believed at the moment, right?
Right, sir.
Yeah, yeah.
So
Okay,
I
is
think
that
Okay.
fine? Can we stop it now?
last query, sir. Last query. What are
Okay.
the factors which are responsible for the continent? Just you brief it and we'll stop it.
Factors responsible for continence, sir.
Yeah.
So, the
Now,
diet of the patient, the kind of surgery, which is the level of ARM, the kind of ARM it is, if it's a high anorectal malformation or a lower anorectal malformation. Depending on that, the musculature, if it is well developed, poorly developed, that will prognosticate the kind of continence the child will have. So. And the sacral ratio is also important. So if the
Yeah,
sacral
but you
ratio
see,
is
You're talking only about the rectal pouch. Talk before of the nerves.
Yes, sacral ratio.
Yeah, and that is one of the reasons why you look at the sacrum, isn't it?
Yes.
Because when the sacrum is not complete, the chances of incontinence become higher
Right.
because the nerves are not proper. Yeah, and that is something which you can't help it. You can't do anything about it. The surgical factors you can still manage by being a little careful. But when something is not there, you can't create it, especially the nerves.
Yes.
Yeah.
I think this is enough for this
Yeah.
rectal malformation.
Yes.
And, next time, I think some female rectal malformation will be discussed. But I think classification, PNAS classification, being a split classification, and
Yeah,
cricket work, you all three you should know. But
Yeah.
which most commonly which we are using it, that is the wing spread, that is the high, intermediate, low. On the basis of that, your management is best. Okay.
Yes.
Yes, sir. Thank you, sir. Thank
Okay.
you, sir, for
Can we
that
sign off?
statement. Yes, sir. Sir, I'll be sending the Google form in which the candidate will be marked alone, sir. Out of 50, I'll send you the link. So, sir, whenever you get time, you can just fill it up, sir.
Okay. Okay.
Thank you.
We'll
Thank
do
you
that.
so much, sir.
Thank you,
Okay.
everyone,
Okay.
and
Thank you, sir.
to
And
IAPS
good-
for giving this opportunity. Thank you,
Yeah.
Grace, sir. Thank you, sir.
Thank you, everybody, and I hope you sleep well.
Yeah, sir.
And remember all that we have discussed,
Yeah.
Thank you, sir.
and all the PGs who are logged in. I think it's a learning experience for everybody. All the best. Thank you.
Thank you,
Thank
sir.
you, sir.
Thank you, sir. Good night, sir.
Good night.
What the presentation described